Good morning, everyone. So as both Jeremy and Martin have said, our project has consisted of both empirical work and conceptual work. So my task right now is to tell you about some of the empirical studies that we've undertaken over the past 4 years. It's almost an impossible task in 15 minutes, but here goes. The first project that we did was to do a review of published cluster randomized trials. And we selected a random sample of 300 cluster randomized trials in Medline, published between 2000 and 2008. And we had 2 reviewers independently abstract information from each article with respect to the experimental interventions. As Jeremy has said, these can be at both the individual level and or the cluster level. The data collection interventions, again, at both the individual and the cluster levels. Research ethics review procedures and informed consent procedures. And as expected, we found a large diversity of trials in terms of the level of experimental interventions and data collection interventions as well. With regards to the experimental interventions, about 1/3 of the trials had interventions targeted directly at the individual cluster members themselves. Another 1/3 had interventions targeted at participants at the cluster level, such as health professionals, teachers, employers, etc. And then another 1/3 had complex interventions targeted at participants at both the individual and the cluster level. With respect to data collection activities, about 2/3 of trials had collected data via interaction with the individual cluster members themselves, probably as one would expect in a standard patient randomized controlled trial. But of course, multiple trials also collect data from participants at the cluster level, such as health professionals. And then in about 15% of trials, there was no interaction whatsoever with either participants at the individual level or the cluster level for the purpose of data collection. So in these trials, data were abstracted solely from secondary sources. 26% of the trials had no information whatsoever about the ethics review process in the trial, and 31% had no information whatsoever about informed consent. So this is despite the uniform requirements from the International Committee of Medical Journal Editors that these 2 standard ethics protections should be reported in all randomized controlled trials. So as well, these percentages seem to be higher than in corresponding reviews of patient RCTs. So the question is why? Does this reflect poor reporting quality, perhaps, in cluster randomized trials? Does it reflect poor ethical conduct of these studies? Or does it perhaps reflect the fact that there are design features of cluster randomized trials that complicate the interpretation of these standard ethics protections? Or maybe all of the above. So we did investigate factors associated with failure to report these ethical issues. We found that the reporting of ethics review was less likely if the study was published in a lower impact factor journal, if the authors did not use appropriate statistical methodology, meaning they did not adjust for clustering in either design or analysis, and if there was no interaction with participants for the purpose of data collection. So the second finding there I found very interesting as a statistician because it indicates a potentially positive impact of the ethics review process, because it seems as if authors who did not submit the trial for ethics review did not use appropriate methodology. They were more likely to use inappropriate methods. We also saw that the reporting of informed consent was less likely if the trial was published in a lower impact factor journal, reflecting a possible reporting issue. There was no interaction with participants for the purpose of data collection, and when the interventions were targeted solely at participants at the cluster level. So the latter again raises the question, perhaps health professionals or other individuals at the cluster level are not considered as research subjects, or maybe it is thought that their informed consent is not required, and it's unclear at this point anyway whether that is appropriate. So our conclusions from the review of published trials were that, first of all, the reporting of ethical issues in cluster trials appears to be inadequate. Unclear is whether the conduct of cluster trials is ethically inadequate. We do know that the failure to report standard ethics protection seems to be associated with unique characteristics of cluster trials, but does not reported mean that it was not done, and does not done mean that it was unethical. So clearly, we need more information about consent practices, and we need further ethical analysis to determine whether these practices were appropriate. And that brings me to the second project, where we decided to conduct a survey of the authors of this sample of trials. We did a web-based survey of the corresponding authors of the sample of trials. We had both open and closed-ended items. We asked them about their general experiences with the ethics review process of any cluster trials they may have been involved in, their perceived need for ethics guidelines for cluster trials, and then we collected detailed information about consent procedures and the ethics review process in the published trial. Our response rate was pretty good, 64%. Encouragingly, 74% of the trialists who responded said that there is a need to develop ethics guidelines for cluster trials. 70% thought that ethics committees could be better informed about ethical issues surrounding cluster trials. Less than half, though, thought that ethics application forms standardized for various study designs are hard to use in the context of the cluster trial design. With respect to detailed consent procedures in the published trials, 91% said that they did in fact seek ethics approval for the study, as opposed to 73% that said so in the report. 93% said that they did seek participant-informed consent, as opposed to 63% that said so in the publication. When we asked information what consent was for, 76% only sought consent for the experimental interventions. 88% sought consent for data collection. The reporting in the trials did not allow us to really gather information at that level of detail. And with regards to the levels of consent, clearly these trials are complex, and about half of the trials actually sought consent at both individual and cluster levels. Interestingly, almost all the authors who responded to our survey said that they did seek consent or permission from a cluster gatekeeper or some other authority at the head of each cluster. However, this was only mentioned in about 5% of the trials. With respect to the timing of consent from participants at the cluster level, so standard ethics guidelines, conventional ethics guidelines indicate that consent ought to be obtained prior to randomization. From participants at the cluster level, 71% were able to seek consent prior to randomization. However, at the individual level, only 25% of trials sought consent from individual participants prior to randomization. And with regards to information provided to participants at the cluster level, the vast majority of participants were informed about interventions in all the study arms. However, participants at the individual level, in only half of the trials were these participants, or did they receive full disclosure about interventions in all the study arms. So the third project was to do a survey of chairs of ethics committees. And so we did a web-based survey of ethics chairs in Canada, the USA, and the UK. We decided to only include one biomedical committee per institution. So we ended up including all institutions in Canada, all institutions in the UK, and a random sample in the USA. We excluded chairs who indicated that their committee does not review any type of randomized trials. The questionnaire was quite long, 45 minutes, and so our response rate was modest, ranging between 32% in the USA and 39% in Canada. So in the questionnaire, we presented them with 3 scenarios, which were cluster randomized trial protocols. The first one was based on the COMMIT trial, which Jeremy introduced to you. It was a community-wide advertising campaign, but instead of smoking cessation, we used colorectal cancer screening promotion. So this was an example of a cluster-cluster trial. And data collection was simply via random digit telephone calling to gather information about aggregate community-level screening rates. The second scenario, which we presented to them, was based on the professional cluster trial, which Jeremy introduced as well, of an educational intervention delivered to health professionals to reduce the unnecessary use of X-rays for back and knee pain in our example. Data collection was using anonymous information about each practice's X-ray rates, and we also included patient medical chart review. And the third example was identical to the BetNet example that Jeremy introduced, randomizing villages in Cambodia. So we had both open and closed-ended items asking them the type of review that this study would undergo at the institution. We asked chairs to identify who they would consider to be research subjects, objections that might be raised by the committee, and the perceived need for ethics guidelines. So with respect to the first scenario, the cluster-cluster trial of colorectal cancer screening promotion, It was interesting that 30% of the chairs indicated that all residents in the randomized cities ought to be considered research subjects. So that includes residents in the control cities who did not receive any intervention whatsoever. However, 70% tended to agree with what our analysis shows at this point anyway, that they are not necessarily research subjects. 40% thought that residents in the intervention cities who were exposed to the advertisements were research subjects. However, almost all, 90%, thought that those who provided data in the telephone surveys were research subjects. With respect to the second scenario, the professional cluster trial about X-ray use, interesting, 2/3 of the respondents only thought that GPs were in fact research subjects, which is what our analysis tends to show. However, 33% did not consider the GPs to be research subjects, despite the fact that the intervention was targeted at the GPs. Just less than a quarter of respondents would consider all of the patients in the GP practices to be research subjects, whereas we would not necessarily consider them research subjects. 39% thought that those who contributed completely anonymous information about their GP's use of X-rays ought to be research subjects, and 62% thought that those patients whose medical charts were being reviewed ought to be considered research subjects. And with respect to the third scenario, again, 80% thought that all residents in the randomized villages, including those in the control arm that did not receive any bed nets, ought to be considered research subjects. However, almost 90% thought that those who received the bed nets, who directly were the recipients of the intervention, were research subjects, and almost everybody thought that those who provided blood samples for evaluating prevalence of malaria were research subjects. So this was very interesting to compare the perceived need for ethics guidelines. 85% of the chairs did think, they agreed or strongly agreed, that there is a need to develop ethics guidelines for cluster randomized trials, and 93% thought that ethics committees could be better informed about distinct ethical issues surrounding cluster randomized trials. That's interesting to compare with the answers that we received from the trialists, where 74% only thought that there is a need to develop ethics guidelines, and 70% said that ethics committees could be better informed about distinct ethical issues. I at least would have expected the difference perhaps to be in the opposite direction. However, it seems as if perhaps the feeling is that we ought not to mess with the ethics application forms. And just a final slide, we also asked that this is obviously just a small snapshot of all the information that we got from the survey. We have a huge stack of qualitative data that we will still be analyzing. We also asked them to kind of rate the level of difficulty they expect the ethics committee would experience in reviewing a trial presenting a particular ethical issue. And the ethical issue that was identified as having the highest rating of difficult or very difficult was identifying who is authorized to be a gatekeeper. And also challenging was ensuring that clusters or cluster members are not disadvantaged by trial participation, determining what information to convey to cluster members regarding the trial, and also identifying who are the research subjects was considered difficult or very difficult by half of the respondents.